Welcome to the Explainer. Today, we're going to talk about something almost all of us have worried about at some point, the common broken wrist. And, as you're about to see, the story behind fixing it is way more complicated than you might think. So, here's our game plan. We'll start with just how common this break is. Then, we'll look at how doctors actually figure out how bad the damage is. After that, we dive into the huge debate over how to treat it, check out the cool hardware surgeons use, and finish with a really important message this injury might be sending. All right, let's get into it. You know the scene, right? It's almost a reflex. You trip, you fall, and you instinctively throw a hand out to catch yourself. Next thing you know, there's a sudden, sharp pain in your wrist. Well, that right there is the classic story behind what's known as a distal radius fracture. And we're not talking about some rare injury here. In the United States alone, this happens more than 600,000 times a year. To put that in perspective, these wrist fractures make up about 1/6 of all the broken bones seen in emergency rooms. It's easily the most common break in your entire arm. Now, you can break your wrist in a bunch of different ways, but the most famous one has a name, the Colles fracture. It's named after a surgeon, Abraham Colles, who first described it way back in 1814. It's the kind of break that can cause this very specific bend in the wrist, making it look kind of like a dinner fork. So you're in the ER with a painful, swollen wrist. How does a doctor go from that to a real plan? Well, it all comes down to the X-ray and taking some very specific measurements. They're basically looking at the geometry of the break using 3 key numbers. You've got the volar tilt, that's the angle of the joint when you look from the side. Then there's radial inclination, which is the sideways angle. And finally, radial height. That's just checking if the main forearm bone is still the right length compared to the other one. For years, everything thought the goal was simple, just get these numbers back to normal. But, well, it turns out it's not quite that simple. I mean, it makes sense, right? If you make the X-ray look perfect again, the patient should be perfectly fine. But is that actually true? The evidence here gets surprisingly murky. Yeah, this is where it gets really interesting. Researchers have found plenty of patients who are totally happy, no pain, great function, even when their X-rays look, well, not so great. The bones didn't heal in that perfect anatomical position. And this little fact is what kicks off the central debate in how to treat these things. Right, so this disconnect between what the X-ray shows and how the patient actually feels leads us right to the big question surgeons wrestle with every single day. Do we operate or not? To cut or not to cut? For decades, the go-to treatment was pretty straightforward. Set the bone as best you can and then lock it down in a cast. But more and more, surgery, using things like plates and screws to hold the bone together from the inside, has become super popular. And the choice between the two, it is far from an easy call. And this quote just nails the problem perfectly. It comes from a huge Cochrane review, which is basically the gold standard for medical research analysis. They looked at all the best studies out there, and their conclusion was, essentially, we still don't have a definitive, one-size-fits-all answer. So why is it so tough to figure out? Well, it's because the best studies we have, the highest level of evidence, actually contradict each other. You'll find one study that says there's no difference between 2 treatments after 5 years, and then another one that says surgery is way better than casting. And when you look at older patients, it gets even fuzzier. It's so confusing that even the official guidelines from the American Academy of Orthopedic Surgeons are inconclusive on most of this stuff. Okay, so let's say the decision is made to go with surgery. What does that actually look like? Well, surgeons have a really impressive toolkit to choose from, and they pick the right tool for the job. You've got options like percutaneous pinning, which is a less invasive method where they just slide some wires through the skin to pin the bone pieces together. Then there's the modern workhorse called volar plating. That's where they attach a metal plate and screws to the bone. And for the really bad breaks, there's external fixation, this metal frame on the outside that pulls everything back into place. The choice really depends on the unique personality of that specific fracture. But here's the kicker. Even with all this different high-tech hardware, the long-term studies often find the same thing. Sure, surgery might get you moving your wrist again a bit faster, but when you check back in a year or two, the final result, how you feel, what you can do, is often pretty much the same no matter which path was taken. But what if we've been asking the wrong question this whole time? What if the most important thing about a broken wrist isn't how you fix it, but what that break is trying to tell you about your future? This is where the story gets really critical. You see, breaking your wrist from a simple fall isn't just a random accident, it is a huge warning sign. The data is crystal clear. Having this injury means your risk of breaking another bone later in life is 2 to 4 times higher than someone who's never had one. This completely changes how we should think about it. The medical world calls this a sentinel event. It's like the smoke alarm going off. The break itself isn't the fire, but it's a loud, clear warning that there's a bigger, underlying problem with the health of your entire skeleton. So the break itself is literally a message from your body. It could be the first sign that you have low bone density, which is the classic sign of osteoporosis. This is a massive opportunity to get screened and start treatment that could prevent something much, much worse down the road, like a devastating hip fracture. And the crazy part? Studies show that almost nobody gets tested for osteoporosis after breaking their wrist. So the big takeaway here is this. A trip to the orthopedic surgeon for a broken wrist shouldn't be the end of the story. It should be the very beginning of a super important conversation about your long-term bone health and how to prevent that next, potentially catastrophic fracture. Which leaves us with a final thought to chew on. Maybe we should stop seeing this incredibly common injury as just a problem to be fixed and start seeing it for what it really is, a critical warning and a powerful call to action for our own future health.